Okay, actually we rolled out active bleeding like after a week. A patient started on low molecular weight heparin, enoxaparin, 1 milligram per kg BID for two weeks, and we did not put him in warfarin because he was considered for kidney biopsy. In the near future, and he was overlapped. After that, he was started in warfarin, 6 milligram once daily with excellent INR control, and he is I saw him last week in my clinic. He has significant clinical improvement of his abdominal pain. So the question: this patient have antithrombin 3 deficiency. What will be the effect of IV heparin in this patient? Okay. So is there any role, or is there any dose adjustment, or just to continue?
Well, very much depends on the levels of antithrombin. So I didn't see the levels. If it's not very severe, there is no evidence that we need to make those adjustments actually.
So to continue the same dose of.
Actually, if it's very low, what you can do with heparin is make him worse and clot. Again, so it depends, in my view, on the level.
On the levels, I agree. So that's what we don't know.
I think, because if it is absolute deficiency, it will be, useless. Okay, but if it is like, there is deficiency, it's a low, I think can be used.
Well, if it was 40-50%, I wouldn't bother, but I don't know how low it was.
So it was very, challenging case. His hemoglobin right now is fine. He was started on vitamin B12 injection, 1 milligram per kg, 1 milligram IM per day. Yes, and he was diagnosed to have lupus cerebritis. So we'll go to the.
Can I
yes,
make
go
a
ahead.
comment?
Yes.
Really, in general, when I see clots, as was described, I really try and avoid thrombolytic therapy at all cost. And this is what happens with thrombolytic therapy. There is a very high chance of bleeding, and then you end up with snowballing with one complication to the other. The only time is really if one believes that he's going to go and develop a gangrenous bowel, which is really very rare. Most of those patients I see, at least in my practice, I find, I call them incidental finding in patients with cancer or with lupus or with something else, and they are having a CT scan for looking for, not really for a clot, but for something else, and you find these. And often what I do is keep them on anticoagulants for long term, and I really don't see them developing any complication. The acute ones, and I remember only one case in my practice where we had to do the thrombolytic therapy because we thought he was going to gangrene, and he bled like this one.
Yes, Dr. Fadel.
In the same line also of bleeding, because we do a lot of kidney biopsies as nephrologists, and patients with anticoagulation, usually they are at higher risk of bleeding, even if they have normal kidney function. And just recently we experienced one patient that even she failed catheter guide also embolization, and she ended with nephrectomy. So for this patient, when we saw him again, because even if he's having lupus at this stage with normal kidney function, there is no active sediment, so most likely is non-proliferative. So he was started with a steroid. And the risk benefit, usually we have to balance it, because most of the time they will bleed, because you have to put them soon, especially for a patient with thrombosis and uncommon site. So we give him the balance, and latest 24-hour urine collection now is 0.6. He was just started with a steroid. He's inpatient yesterday. I have seen him. He came with DKA related to the steroid therapy, unfortunately.
Complication, not thrombosis, okay? So, because the same, you can generate a lot of questions from this case. What about if we have a planned renal biopsy for this patient? So, this question for Dr. Ageno. How, post-operative, how soon we should resume anticoagulation with such patient, okay? Because we have, experience, okay? Just last week, okay, we started we resumed anticoagulation 26 hour post. It was planned to be 24 26-hour post-renal biopsy, and we experienced bleeding, okay? Catastrophic bleeding, I would say. What's the proper, okay, timing of anticoagulant? Is it
After a procedure?
renal biopsy? Ultrasound guided renal biopsy?
Well, I agree it is a high risk, high bleeding risk procedure, like most urologic procedures. So I wouldn't be too much in a hurry to resume anticoagulant treatment unless the thromboembolic risk is really high. So in this patient, if you were to decide to perform the biopsy during the same admission, then I would have probably taken the chance to start 24 hours after, as you did. If not, if you, like in the same patient, you wait for 3 months, let's say, I would have probably given him just the prophylactic dose and after 24 hours, and then I would have increased the dose, going back to therapeutic doses, but slowly, and even 48 hours after the procedure, at least.
Okay, Dr. Saour? Dr. Saour, what do you think more? After renal biopsy, resumption of anticoagulation?
I would have delayed the renal biopsy. What is the rush about the renal biopsy?
If it is done, like if it has to be done, what would be, I mean, is there any guidelines we have?
I don't know about guidelines. It's how you assess the risk of recurrence of bleeding as to the risk of thromboembolism.
Okay.
In this particular patient, he is obviously thrombogenic. He's clotting everywhere. So I need to go and anticoagulate him as soon as I can once I believe the bleeding risk is low. Now, if his kidney function is poor, then he is going to bleed more.
Yes.
I would guess, and this is just a guess really, not based on any clinical trials. There are no clinical trials. I would wait, because he is so thrombogenic, maybe wait 1 or 2 days and resume the anticoagulants. However, resume it if we are going to use low molecular weight heparin, then make sure, because of his renal function, make sure it's the right dose. Look at his platelets, make sure the platelets are low. So if the platelets are low, I'm going to have to wait for a longer time.
Okay.
If his renal function is poor, then I will have to delay this and accept. I would always, in these patients, tell them, if I'm going to stop your anticoagulation, you are highly thrombogenic, there is going to be a risk of a clot. And truly, there will be a risk of clot. He must understand, and I often make really a joint decision between myself, the nephrologist or radiologist, whoever is going to do that, and the patient, and explain to him, because, you know, bleeding can happen anytime, really, in the best of hands.
Just to go to the next case, yes, clearly this is acute thrombotic event. I mean, it's best to be delayed after the acute passage of the acute phase, like after 3 months. Speaking for another patient, was done 3 months. But this patient, yes, shouldn't be done at this point of time. It has to be delayed, like after the acute thrombotic event. So we'll proceed to the next case, which is, yes.
Excuse me, Mohammed. I was interested in asking whether antiphospholipids were repeated after at least 12 weeks, and if they tested positive again, and if the titer was
actually repeated. I don't recall the figures, but it's rising titer, so it is higher than the first one. Okay, the repeated one. So initially we thought it's negative. Okay, but the repeated one in the clinic after 12 weeks, it's rising. Okay. That's why I labeled him as antiphospholipid antibody syndrome, because of the repeated antiphospholipid antibodies, it's rising. So we'll proceed to the next case, less challenging from the first case. So this is second 62-year-old male patient who presented to ER with a severe shortness of breath at rest and painful left leg swelling, status post hip fracture surgery. in a private hospital 3 weeks prior to his presentation. He was given DVT prophylaxis inpatient, but he was not given extended DVT prophylaxis. You know, the standard of care, you at least you give like 2 weeks, 10 days to 2 weeks post-op, and can be extended to 35 days. So he only received inpatient DVT prophylaxis, and when he presented to the ER, his vital signs, he was tachycardic, blood pressure 125/85. He was desatting, requiring 5-liter oxygen to reach 98%, and weight 80 kg. Chest X-ray was crystal clear. Serum creatinine was elevated 138, and hemoglobin was 12.8, platelet 570, and INR 1.1. These are the most important parameters in any thrombosis case. So how would you work up this patient, and what are the treatment options? We'll proceed, okay, in the case, then we'll take your opinion. So CT pulmonary angiogram, because the initial presentation was the chest pain, the shortness of breath, and Doppler ultrasound, troponin, which was elevated, ECG sinus tachycardia with right ventricular strain pattern, echo showed confirmed. So we have, laboratory and echographic evidence of right ventricular strain. This is the CT pulmonary angiogram showed, filling defect in the right main pulmonary artery, as well as in the left. I don't have all cuts, so this is, it is occlusive, and the other we can see here another filling defect. This is the Doppler ultrasound. So this is the left superficial femoral vein. This is before compression. After compression, it is non-compressible, and there is evidence of the thrombus, and it's extending to the popliteal vein. Also here, this is non-compressible, and I have, as I mentioned earlier, the high troponin, ECG, and echo evidence of right ventricular strain pattern. So this is provoked extensive proximal left leg DVT and bilateral extensive VE, more in the right, without hemodynamic compromise, apart from desaturation and right ventricular strain. Actually, the radiologist reported the CT massive pulmonary embolism, and we have communicated clearly with the radiologist. This is a clinical diagnosis. This is not radiological. So this is because it's misleading for many physicians. So this is, I think, the final diagnosis, submassive PE, and would like to hear from the panel. Okay, what should be done for this patient?
This is, to me, submassive PE. There are two schools of thoughts as to how to best manage these, and basically it's an option of giving a patient thrombolysis or giving the patient anticoagulant. I am personally of the opinion that for submassive pulmonary PE, while the patient is clinically stable, I do not favor thrombolysis, and my reasoning is every time, well, not every time, really, the risk of bleeding with thrombolysis is quite high, much higher than with anticoagulants. And most of these patients, actually, after a while, the natural history of these clots is to slowly resolve and improve. So unless the patient, this is my practice, unless the patient is hemodynamically unstable, I do not go for thrombolysis.
So conventional anticoagulation,
That's
yes.
right.
That's okay.
I don't know, what do you
Marco,
think,
you want
doctor?
to-
What's
okay.
your practice?
It's a very interesting case because you are right, especially the European Society of Cardiology guidelines open the possibility to normalize in these patients with weak recommendation, but in this case with the right medical dysfunction. But the very last ACCP guidelines
published, so published right now, or?
A switch back to use thrombolysis or not to use against thrombolysis.
Sorry, because the evidences are not there yet. I mean, we do have evidences of an increased risk of mortality with these signs of right ventricular dysfunction, but there is no evidence that the risk-to-benefit ratio of thrombolysis in this population is an advantage, and the only randomized control trial, the PATHOS study, is still ongoing and has been ongoing forever, so I don't know when we will see these results. So it's interesting to observe that the very recent ACCP guidelines have really changed, going back, saying be careful with these patients, not push it too hard, because we don't have really the evidence. So I fully agree with what has been said. I will also not treat this patient with thrombolysis, also because he underwent a surgical procedure 3 weeks before. I would not probably feel comfortable. So I fully agree. I would also give him standard anticoagulant treatment in this case. I might be open to some very selected patients, very low risk of bleeding, younger patients. Maybe it can be worth the, but again, we don't have final definitive evidences.
Just a quick question. We often confront patients with submassive PE who have echographic findings of RV strain, who clearly are not hemodynamically unstable but have a huge burden of clot and sometimes have renal dysfunction precluding the use of agents like enoxaparin, and you end up putting them on IV heparin. And oftentimes there's a struggle in our mind as to whether to put a temporary IVC filter in these patients to basically protect them from a fatal pulmonary embolism while they have massive clot burden with involvement of the main pulmonary trunk with compromise on the echo. How would you select such patients to sort of use the IVC filter? Because I know this is controversial and not sort of clearly indicated, but at least from some of the pulmonologists that I have worked with, in the States, would clearly sort of advise us as trainees that protect patients from fatal PEs, and it's okay to put a temporary filter in. I would just like your comment on that. Sure.
I don't want to monopolize the. I don't know if anyone else. I think you made a good point saying that in the United States, I think it very much depends on where you were trained. In the US, the IVC filters are used much more than in Canada or in Europe. So the approach is quite different.
They are generous.
With regard to IVC filters. I think the Canadian, and I'm biased because I did some training in Canada and I work in Europe, so our approach is more conservative. And we consider IVC filters only in the presence of major contraindications to anticoagulant therapy. So the patient is bleeding or he had a recurrence despite adequate anticoagulant treatment. In the case that you were alluding to, renal insufficiency would not be a reason because you can use unfractionated heparin, which would be, in my opinion, a perfect treatment for these patients. So I would not use in this case an IVC filter. That's my personal view. But I know many U.S. colleagues would be more. And these retrievable filters can be useful because they can be retrieved in a short period of time. But I would not use it in this case personally.
There is a problem with the retrievable filter because in real life, in a perfect life, they will be retrieved. In real life, 50% of them are not retrieved.
If they placed for a long time?
And I remember reviewing a paper for the for thrombosis research only about 9 months ago. And, it was obvious this is what is happening to them. And the way they suggested around it is to actually make an appointment for the patient on discharge with the same person who put the filter so that he will remember to take it off. So retrieval filters may be an option, but you must remember in real life, in our experience in our hospital, more than half of these retrieval filters were not actually removed, and we ended up with a patient on long-term anticoagulants.
Just one more follow-up question, just because I'm a little bit, again, based on my training. These young patients, for example, who have submassive PEs with extensive clot burden, and let's say they have clear renal dysfunction and you have to use IV heparin, where the PTTs go like this, and you're always nervous, are they staying therapeutic, more times than subtherapeutic, they're supratherapeutic, they're the subtherapeutic. And after losing a patient or two young patients with a similar histories, I think the practice may be changed based on what your experience is. So if you lose a couple of patients who have exactly the same issue, do you think that's a reason enough to change practice, which is clearly not based on any clinical guidelines, but it's just a sort of intuitive thing where you do have a lot of clot burden, you want to protect them from that fatal PE? So if you were to lose a couple of patients or 3 patients in the situation like this, would you change the practice on the 4th patient and do put an IVC filter in that's potentially retrievable, for, in a month or 2?
I learned from my patients. If I lose 3 patients, I would change my practice. I am not dogmatic. In my experience, most of those who come with subacute pulmonary embolism, some people will put them in ICU and give them thrombolysis. I admit them to the main hospital, and they've all done well. I cannot remember a patient that really did poorly. If you tell me even within a year I lose 3 patients, of course I'm going to change my mind.
Marco, you want to comment?
Well, no, I agree with what Professor Ageno told. Also, for my kind of, let's say, idea, I would not treat this patient with an IVC filter, even though, of course, the fact that there is absence of evidence, it is, let's say, not equal to the evidence of nothing. So it's depends, patient by patient.
I think
if I
clear.
could make a point, if you look at the definition of what is evidence-based medicine, it's not only the clinical trials, it's also expert opinion, and it's also the morality of society where you work. So unfortunately, we forget the last 2, and we latch into trials, and sometimes there are no clinical trials. Really, often in these difficult cases, there are no clinical trials to tell you one way or the other. So you must fall back on your own experience. This is why I told you, if I lose 3 patients, I'm going to change my mind.
I think yes, go ahead. You want to say something?
No, just one minor additional comment. Don't forget that you can have complications with IVC filter placement and removal as well. So the idea that some interventional radiologists have that you place it and it's no problem, but we saw some filters that moved to the right atrium. There have been some cases. I mean, I agree with what you're saying, personal experience, and I can say that over the years I've seen some troubles with the filters as well. So it's not a sort of painless and a priceless solution all the times.
I think it's in presence of massive PE and concomitant DVT. It's a relative indication for IVC filter because of any further embolization might decompensate the patient. It's one of the mentioned relative indication of IVC filter insertion if you have massive BE with concomitant DVT, because any further embolization, it might also in the presence of chronic thromboembolic disease, further embolization might decompensate the patient. It's a controversial topic. It's
if I remember well, the practice in Pittsburgh, I think it's Pittsburgh, where they had the largest series of thrombectomies for severe pulmonary hypertension. They would just put a filter prophylactically before they do the surgery.
Yes.
And then hopefully not forget to retrieve it.
It's okay. Okay, so this patient was treated initially with IV unfractionated heparin because of the renal impairment. Then he recovered his renal function the second day. Then he was started in low molecular weight heparin, overlapped with vitamin K, and he achieved the therapeutic INR within 5 days, and he was decided to be treated for 3 months. He did remarkably well. It was, provoked by major transient risk factor, the orthopedic surgery. So this is just, 2 slides about thrombolysis for PE. About less than 800 patients have been randomized in clinical trials to thrombolysis or heparin for acute PE. One overview of 11 studies with PE of varying severity showed no significant reduction in recurrent PE and all-cause mortality or major bleeding. And different regimens used, and the incidence of major bleeding is quite high, 8 to 20%, and the incidence of intracranial hemorrhage is 2%. Just remember, heparin is 0.2%, and this is 2%, like it's 10 times, okay? And twice the number of intracranial hemorrhage with thrombolysis for PE as compared thrombolysis for acute MI. And when you have intracranial hemorrhage, its fatality is like 75%. And this is the regimen used, TPA 100 milligram over 2 hours. There are so many regimens, but this is the most commonly used. And we should start heparin, okay? Not low molecular heparin. And this is, this is very important slide. This is general agreement that thrombolysis is indicated in patient with hemodynamic compromise. And it is controversial in patients with submassive PE and no evidence of hemodynamic compromise. And this is a very important, statement. In selected high-risk patients without hypotension who are judged to be at low risk for bleeding, we suggest thrombolysis. Because when I was working in McMaster, some of the thrombosis experts, they treat submassive with, thrombolysis. Regarding this, I think till right now it's a gray zone. Okay, we don't have clear evidence till we complete there are 2 ongoing randomized clinical trials for submassive PE, multi-center international trial, one in Europe and one in States. I think been recruiting patients since 2008. Till we have the result, I think we should not proceed with thrombolysis. We should wait for the robust evidence. And this is the 3rd case.
This is the last case. Actually, we'll quickly go through this. It's a case of a 32-year-old Saudi male with a history of type 2 diabetes and primary infertility related to oligospermia, who presented to the ER with a history of left-sided hemiparesis. His MRI showed an ischemic stroke involving the right putamen and the posterior limb of the right internal capsule. During the hospitalization, he developed new weakness bilaterally, and repeat MRI showed infarctions in different stages of evolution involving both basal ganglia and a new acute infarction in the left putamen. Weight 85 kilograms, serum creatinine of 75, hemoglobin 13, platelet count 250,000, INR 1. The same 2 questions of how we would work up this patient and what the treatment options are. The workup that was sent is as follows. His ANA and ANCA were negative, rheumatoid factor and complements level were normal, protein C, S, normal, antithrombin 3, homocysteine levels normal. He was negative for factor 5 Leiden, and the rest of the studies were negative, other than there was homozygosity for the G20210A mutation in the untranslated region of the prothrombin gene. His transesophageal echocardiogram showed insignificant patent foramen ovale with a negative bubble study. Vascular ultrasound of the bilateral lower limb veins was negative for DVT. He had a cerebral angiogram done which demonstrated multiple areas of stenosis. The frontal cortex and dural biopsies revealed no evidence of vasculitis. So this was a case of homozygous prothrombin gene mutation with recurrent ischemic strokes. Just like some input from the experts on what they think about this case, and
You know, in the registries we had almost 2,000 patients that we looked at this, and we had few with heterozygous. We really did not have even one case.
This is the first case in Saudi Arabia we looked after.
I don't know if it's been reported, but yeah, at least in our 2,000 patients, we did not find anybody with homozygosity. Family history, is that positive?
No family history at all.
It's negative?
Yes, and no history of
really
venous
interesting
thrombolism.
because homozygosity in these is quite a significant risk. So I thought his brothers, sisters, that's full brothers, full sisters, may well be at high risk. Actually, they are not.
Actually,
So does he have any other risk factors like he has diabetes, okay.
Yes, but apart
smokes, hypertension,
is non-smoker,
dyslipidemia.
non-hypertensive, not dyslipidemic. No other vascular risk factor. Just hear from.
I mean, in the main, these develop venous thrombosis, but they also develop arterial thrombosis. We don't have much data on the heterozygous because there are so few of them. But there are case reports where you get heterozygous of prothrombin mutant gene and another factor V Leiden, and these patients tend to be even more thrombogenic than the heterozygous. And some of them do develop arterial thrombosis.
So the heterozygous in the Western community, like Caucasians, 2%, okay? Here, you showed in your study, it was 0.6 or in
our normal population, it was 0.68 in the normal population.
So what do you think?
So it's really quite rare. And this was all heterozygous. We did not see any homozygous.
Just to...
It's not much to add to that because I think he really made all the investigations. I mean, I would have probably guessed at the beginning more on a cardioembolic source, which was excluded, or an autoimmune disease, which was excluded. I would say that I would have concluded with the same diagnosis, although I must be very honest, and I would have written the same thing in his final discharge diagnosis, but somewhere in my mind the doubt that this is a sort of coincidence and there's something else that we missed, but I don't know absolutely what would remain, but that's to be very honest. I would have no ideas though on what else to suggest. So.
They have done extensive workup up to the, craniotomy and brain biopsy. So they concluded it's normal, okay. They did all the workup. So we actually were skeptic about the result. I mean, homozygous, we rarely see, heterozygous. To see homozygous, this is unusual in our community. But regarding the, we were debating with the neurologist. They dismissed this finding. This is not relevant to the presentation. From our thrombosis standpoint, we don't have any alternative cause. So we have only this prothrombin gene mutation, and prothrombotic risk is quite high with homozygous compared with heterozygous.
Just one final comment and then I'll shut up forever. No, I just want to say that although it is a controversial issue, there is a recent study from the Milan group, from Professor Manucci's group, supporting the fact that this kind of thrombophilia is associated with strokes in young adults and in children. So, recent evidences may support your conclusions. So I think
I really, before the test, I thought this was cardiogenic. I thought
but was
this will turn to be something from the heart,
transesophageal echo,
even endocarditis, something like this, where you get sudden bilateral. Yeah, I understand.
IV drug abuse. No history of IV drug abuse.
If you allow, Mohammed, one more disease. Especially for when we look for stroke in a young, because related to the kidney, and we sent for, and we know it associated usually with stroke, with left ventricular hypertrophy and cardiomyopathy. Fabry's disease, just keep in your mind.
Fabry disease.
Fabry disease, yeah. They may present with stenosis, stroke, young. Always keep it in your mind, I mean. And it's very easy. You can send for the mutation. The company, they come. We have 2 companies here. They can send it within 2 weeks. They will send it to your email with a code.
Yes, thank you. What's the thrombotic risk? I mean, if you have homozygous, okay? Because we know if you have heterozygous, it's 2-fold increase. But what about homozygous? Any
homozygous in the factor 5 Leiden is better studied than this. So
Okay.
it's much more than 2. I really cannot recall.
And I have some,
I know the figure.
I have some
Did you
literature.
look up at the
Yes, we
figure?
have some literature.
Yeah, I can't tell, but I suspect it will be high.
Yeah, so he was, this patient treated with the low molecular heparin overlapped with warfarin for 6 days. And he's currently following up thrombosis clinic with a fluctuating INR without CVA recurrence or VTA manifestation. Family screening for thrombophilia parents reveal heterozygous prothrombin gene mutation. And we ask, other family members to be checked for prothrombin. Okay, so this is to confirm our finding because we don't have homozygous. This is the first case. I mean, we looked up the literature, okay, in Saudi Arabia, and this is just to have some that if you have prothrombin gene mutation heterozygous, just remember heterozygous prothrombin is factor 2, so it is 2% incidence. And prevalence and 2-fold, almost 3-fold increase. But if you have homozygous, it's very rare. This is in the Caucasians, okay, 0.01%. Here, I don't know what. This is even more rare, and it is 80-fold. I did not put the reference here. It is. I found it in some of the publications. 80-fold increase. The neurologist not convinced this is like prothrombotic disease, okay, and can cause 80-fold increase. And particularly weak thrombophilia, if they are heterozygous, usually augmented if you use other, if you have other VT risk factor like oral contraceptive pills, pregnancy, or other thrombophilias. And combination factor 5 Leiden and heterozygous. We call it compound thrombophilia. And if you combine OCB with prothrombin gene mutation, you have like 16-fold increase, 16 from 2-fold. And this is just found some case report in the literature, okay, to say this is homozygous. Prothrombin gene mutation can cause CVA, but however, this is, case report. We need, more, data on this, okay. So we cannot draw firm conclusion, but this is so far we have, okay. And I'd like to hear from you, okay.
Thank you, Dr. Arshad, Dr.sheef, and thank you, speakers, Dr. Ageno and Dr. Marco and Dr. Saour. See you tomorrow, inshallah, second day of the conference.
And I thank the attendees and the presenters. We're going to start our sessions today with Professor Warter Ageno. He's associate professor at the University of Insubria. Perfect. And he's also a full-time staff in the Department of Internal Medicine. I see that he heads the research center of thrombosis and anti-thrombotic therapies in that hospital, and is a counselor or a member of a number of international committees of thrombosis, as well as sitting in the advisory boards or editorial boards of several journals. And I welcome him today, and he's going to talk about unusual sites of thrombosis. Please come, Dr. Warter.
Thank you, Mr. Chairman, for this very kind introduction. Good morning, everyone. It is my true pleasure and honor to be here with you today, and I really wish to express my most sincere gratitude to the organizers for their very kind invitation. It's really nice to have these possibilities to have these multicultural exchanges. Once I find that what is full screen here, I will start with my talk. Here it is. Right. So the first talk of this morning is on a topic that I really very much care about. I've been working quite extensively on these issues over the last years, and I'll try to give you a sort of overview of what we know about unusual site of thrombosis, but mostly, and this is the reason why I've been that interested in the topic, what we still need to learn about unusual sites of thrombosis. First of all, I think the question is, what are we talking about? What is unusual sites thrombosis? So very largely, the definition means simply, conventionally, any clot forming in a vein outside of the lower limbs or the the pulmonary arteries. So theoretically, we're talking about any other vein thrombosis that may occur in the body. However, when we talk about unusual site thrombosis, we mostly refer to probably the two most important, or the three most important groups, which include cerebral vein thrombosis, splanchnic vein thrombosis, and retinal vein occlusion, although again, we may really include any other site. So I will start with a very synthesized introduction with the aim to show you what these unusual sites, venous thrombosis, have in common and what they do not have in common among each other, and what they do not have in common with usual site thrombosis. So indeed, we are talking about an unusual event, and so we expect these events to be rare. However, although while I'm talking you can appreciate the data we have in the incidence, I can assure you that these data are really very likely to be incorrect. And the reason is that we are talking about quite old studies, and a very simple example it refers to, for instance, portal vein thrombosis. It is clearly much more common than it is reported here, but this is the incidence that everyone still cites as a reference, because this is the only probably epidemiological study that we have. On the other hand, though, if you look at the reported incidence of retinal vein occlusion, for instance, and you compare it with the incidence of deep vein thrombosis of the lower limbs, then you realize that probably this incidence is a little bit better updated, and the disease is not that unusual as compared to lower limb vein thrombosis. Another thing in common, as I said, mostly because these disorders are certainly less usual or unusual whatsoever, it's the lack of adequate studies. There's probably been also some lack of interest, and it's certainly very difficult to run studies. As a consequence, we nearly have no randomized control trial. So when we are talking about treatment, it's really not evidence-based the way we think today. We do have a few studies, but they're very small in their sample size, and so very limited power to allow us to draw any conclusion. So we mostly rely on the results of observational studies, and large majority being retrospective, and thus also with some very high risk of selection bias in the populations that are studied. So everything that we say about this disease must be always taken with some caution, especially when we will discuss about the numbers. For every clinician, I think it's quite clear, especially for all of us working in the thrombosis field, that these are anyhow true clinical challenges. So regardless on how common or rare these diseases are, we're really very challenged when we face patients with suspected unusual side vein thrombosis and then with objectively diagnosed unusual side thrombosis. A very simple example on why these are challenging is that conversely from deep vein thrombosis of the lower limbs or pulmonary embolism, where the patient may be actively bleeding for other reasons, but this is a coincidence that it's quite rare, these disorders not rarely have as the onset a bleeding manifestation. So you may end up with a CT scan of the brain, or better, an MRI of the brain in a patient with cerebral vein thrombosis to observe a possibly large intraparenchymal bleeding, and that occurs in up to 25% of the patients. You may have a patient with splanchnic vein thrombosis who is experiencing gastrointestinal bleeding, possibly as a consequence of his thrombosis, and this has been reported in up to 25% of the patients, depending on the series. And retinal bleeding is another common situation in patients with retinal vein occlusion. So, of course, this makes our treatment strategies quite challenging. And the clinical pictures are largely heterogeneous, as I will comment later on. A very interesting issue which has been brought up over the last years refers to the provoking mechanism. So we might think that since we are talking about venous thrombosis, the provoking factors are all the same. I would say that what is common, certainly with all sites of thrombosis, is the main mechanism defined by the role of the Virchow triad that yesterday has been extensively discussed, and it is we are all familiar with it. So the basics of the pathogenesis are probably common, but the risk factors are not. We will see that gender-specific risk factors are extremely important for cerebral vein thrombosis, and these impact very much also the epidemiology of this disease. We are learning that splanchnic vein thrombosis is very strictly connected with some hematological disorders, including myeloproliferative neoplasms. And you will be surprised to see that, especially when a retinal vein occlusion occurs after age 50, cardiovascular risk factors are by far the most common risk factors that you will find in these patients, and there are some plausible explanations for that. So we have things in common with usual site thrombosis, but many are not, and it's quite interesting and challenging. And of course, not only the clinical presentation is challenging, but also the clinical outcomes can be severe, and that means that we cannot certainly neglect patients with these disorders. Residual neurological impairment or epilepsy can be a consequence of cerebral vein thrombosis. Liver cirrhosis or portal hypertension, just to name a few, can be consequences of splanchnic vein thrombosis, very important consequences, and of course blindness for retinal vein occlusion. So that was an introduction, an overview on what is quite unique to this unusual site thrombosis and the reasons why we really face very important challenges when we manage these patients. Now, I will discuss with some more details the two most important clinical events here, cerebral vein thrombosis and splanchnic vein thrombosis. For the sake of time, I will not go into retinal vein occlusion. I'm sure we will have some time for discussion. I will be very happy to discuss also retinal vein occlusion, at least in some practical, under some practical aspects with you. So what about cerebral vein thrombosis? What have we learned over the last years? So if we look at the distribution of gender and risk factors using the largest cohort that has been published so far, and this is the ISCVT study, which is a network, the result of a nice network of neurologists over mostly Europe, you will notice two very important things. The first being the large majority of patients were women, 465 as compared to 159 men. That's quite different from other sites of thrombosis.
You will also notice that unprovoked events were not that different in terms of proportion in men as compared to patients with more usual site thrombosis, but quite infrequent in women. Risk factors are different, of course, but you see the prevalence of infections, cancer, mechanical precipitants is not very high, whereas in women you will see that as many as 65% of patients had a gender-specific risk factors, in most cases being the use of oral contraceptives. So women mostly affected by this disease and gender-specific risk factors, not surprisingly, extremely important in the pathogenesis of cerebral vein thrombosis. This is another large study that we hope to publish over the next month or so. It's almost accepted in an international journal. This is the Sevetis study that we have carried out. This study is retrospective, I must say, but it's quite large. We included more than 700 patients, so that will be the largest study on this topic, and it's very much confirms the gender-related issue. 3 out of 4 patients were women. The other thing that you will notice, and that is very much in line with the first study and with the first studies on this topic, that the mean age of onset of this disease is clearly much lower than that for the vein thrombosis of the lower limbs. We are here talking about patients who had the event in the average at 40 years, so much younger patients. And again, we also found this very important association with hormonal therapy or pregnancy and puerperium altogether. We are again in the ballpark of 65%, so very similar results as compared to the previous very large cohort that I presented to you. But we also found a quite high prevalence of thrombophilia. And in a previous meta-analysis of risk factor for cerebral vein thrombosis, we found that in particular prothrombin gene mutation is associated with cerebral vein thrombosis, and the strength of the association is greater than that of factor V Leiden, which was also associated. So thrombophilia, together with the use of oral contraceptives in particular, may justify this prevalence, high prevalence in the young women. There is a chance that we are also underdiagnosed in this disease, and there are several reasons. Of course, the first one being that most of the clinical presentation, we have very heterogeneous clinical pictures, but there's only one symptom that is really very common in these patients, and that is headache. Almost all patients have a history of recent headache, and it's usually described as a very intense, unusual headache. So it's, even if patients had headache in their past, they will tell you that it's totally different. It's very important headache, and this leads often these patients to be visited by neurologists for this persistent headache. And of course nowadays, at least in my institution, in other Italian institution, if neurologists see these kind of patients in their ambulatory only with headache, and they are young women, especially if they are taking oral contraceptives, they will ask magnetic resonance right away, maybe exaggerating sometimes, but there is a sort of alert in this population. Maybe if a patient is a man and slightly older, this threshold will be lower. Maybe some of these cerebral vein thrombi only presenting with headache are missed in other populations. This is a possibility. Many other clinical presentations, the disease can have an onset that is similar to arterial thrombosis in the cerebral arteries with paresis, aphasia. Another common presentation are seizures that can occur in up to 40% of the patients according to the IS-CVT study, and 14% with coma. So we have quite different clinical pictures going from intracerebral hypertension to typical presentation of arterial stroke to simply headache. So this is, of course, challenging. I will not discuss the diagnostic pattern, but indeed the gold standard right now is MRI, although angio CT scans are certainly getting more accurate, although at this stage I would still define MRI as the gold standard. What do we do when we have the diagnosis? As I said at the beginning, we cannot really rely on the on clinical trials to drive our decision. And as we do in these cases, we tend to use what we have learned with more usual sites of thrombosis. And so we consider anticoagulant treatment as the first choice. There are very little evidences for unfractionated heparin because two studies, very small studies, in each one less than 100 patients enrolled, compare unfractionated heparin with placebo, and as compared to placebo, unfractionated heparin was clearly effective in reducing mortality and the outcome death dependency by, as you see, 70% and 56%. Of course, there is a risk of bleeding. One study only, very small, has compared low molecular weight heparin with placebo. We cannot say that there is evidence, but certainly this is the experience we all have. And in the absence of evidences, what we have tried was to use clinical judgment of experts. A couple of years ago, within the Italian Society on Thrombosis and Hemostasis, since guidelines usually say that there are no evidences and the degrees of recommendations are, of course, extremely low, we decided simply to discuss this with some within our society and involving some international experts, both neurologists and experts in thrombosis, and we discussed on very simple questions, and we just came out with some practical recommendations based on our clinical experience in these cases is of course important. And as you can see, for the question, can we use low molecular weight heparin or unfractionated heparin, everyone agree on the fact that this is the treatment we should use. There are some experts prefer unfractionated heparin because of the shorter half-life, and because these patients commonly present with concomitant bleeding, they felt more comfortable to use unfractionated heparin. Many other of us have more experience with low molecular weight heparin, so we all agree that this can be the initial treatment. Another interesting thing is that, that was my wake-up call, so I think I apologize for that. That's why it didn't work this morning. So you can be jet-lagged up with 2 hours difference as well. That's incredible. Sorry about that. So the second question was, would you start warfarin from the very first day, or would you wait a little bit? And everyone agreed on the fact that given the very difficult balance between risk and benefits in these patients who commonly have intracranial bleeding as well, everyone agreed that in these patients you should wait to introduce warfarin at least for a few days, and also in order to administer heparins for longer than the usual 5 to 7 days. And some experts who believe that this will produce a better thrombolytic effect, mild thrombolytic effect with the use of heparin if this is extended. But most of all, it's a safety issue. Just wait to introduce warfarin until you're sure that the patient is stabilized and his bleeding will not increase. Although there are no evidences that even if the patient is bleeding, there is no evidence that if you give him anticoagulant drugs, the bleed will worsen, and probably because this bleeding is caused by the occlusion of the vessel and the hypertension that is that is caused locally. Is there a role for thrombolysis? Very, very restricted. We published a meta-analysis a few months later showing that thrombolysis should really be used for very selected, very severe cases. The risk of bleeding is not negligible. And so we all agree that thrombolysis is really something that we should keep in mind, but we need to reserve it for a few patients. So we have made our diagnosis, not an easy task. We have started anticoagulant treatment using this approach. What is the natural clinical history, better say, of this disease? Well, the good news is that It appears to be a more benign disease than arterial thrombosis in the cerebral district. In fact, look at here, total mortality. This is a systematic review of the literature we published a few years ago. Total mortality 9.4%, much lower. It's not negligible, but much lower than that after arterial stroke. And most of all, complete recovery in patients who survive quite high. Almost 90% of patients will have a complete recovery. So